be the facilitator of the day, and I'll ask that in case again my connection dies, Damaris takes over, but I hope to last through, and I enjoy like everybody else.
Sounds good.
You're
Thank you.
welcome, everybody. I don't know how much Damaris had said, but for those who are new, this is the African tea time, and we are going to have two presentations. One by Dr. Mati, which will come first, and it is titled The Challenge of COVID-19 and HIV/AIDS on Families and Communities in Botswana. The second presentation will be by Jorem, and he will be talking about autism assessment and rehabilitation, a tale of unmet parental needs in Uganda. So very interesting topics for the day. How we've been doing it is we let the presenter take us through. You can either type your question in the chat, and then after the presenter, we fill those questions over to the person or the presenter at the end. Our talks last an hour for each presenter. So we're going to have 1 hour talk from Dr. Mati starting now, and then we'll have questions after that before Jorem takes over. So you're most welcome, everybody, and thanks for joining us for the African Tea Time.
All right. Thank you, everybody, for attending the talk here. Like he already said, I am Methi Kelepile. I'm a lecturer here at the University of Botswana in the Department of Environmental Science at the University of Botswana here in Gaborone. And my time right now in Gaborone is 11:05 p.m. So my topic is the challenge on COVID-19 and HIV/AIDS on families and communities in Botswana. So first of all, let's know a little things about Botswana. Where is Botswana located? Botswana is located in the southern part of Africa, where it's bordered by Namibia to the west, Zimbabwe to the east, Zambia to the north, and South Africa to the south. So the population of Botswana, it's a small population, is 2.2 million, and the size of Botswana is about the same size of Texas, to put it in that context. So the capital city of Botswana is Gaborone, and the president is called Dr. Mokgweetsi Masisi, and he became the president a little bit 2 years ago in 2019. And Independence Day in Botswana is celebrated every end of September. We got our independence from Britain in 1966. The election and we have a parliamentary system. So the elections take place every 5 years. And the last one that we have was in 2019. And the next one is going to be in 2024. So right now, our current ruling party is called BDP, or the Botswana Democratic Party. It has been on power since I was born, and is still the ruling party. So there are several ethnic groups or the tribes in Botswana. So the largest by far is the Botswana people, and it's the Tswana people, sorry for that. So they are made up of 8 main tribes, and they make 80% of the total population. Even though we have these 8 main tribes, there are other tribes, and we have them such as Bakalaka, Basarwa, Basubia, Bayeyi, and the Hambukushu. So collectively, all the ethnic groups are called Botswana, the people of Botswana. So plural is Botswana. One person in Botswana is called Motswana. So there are 2 official languages here in Botswana, which is Setswana, the national one, and English. The currency of Botswana is called Pula. Pula is a Setswana word for rain or blessing. So that gives an aspect to show you that like rain is very important in Botswana, because Botswana is a semi-arid country. It's known for its mighty Kalahari Desert, which is found on the eastern side of Botswana, which covers about 80% of Botswana. So having this landmark makes our climate to be mostly arid or semi-arid. So we do have some rainfall, even though it's not as much, but it's there, and it occurs mainly in the summer. So the summer period is now, as you can see that I am rocking my MSU t-shirt here. So it's between is it November up until March, April. So that's when we get to experience some bit of rainfall. Botswana is also known for the Okavango Delta, which is one of the world's largest inland deltas in the world. And the Okavango Delta is known for its abundant bird and wildlife population. Diamonds, 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 diamonds. So Botswana is a diamond country. Diamonds are the highest exports because they make about 50% of the government's revenue, and they are mined by a company called Botswana. So it's a 50-50 venture between DBS and the Botswana government. So DEB for DBS and Swana for Botswana. So the richest mine in the country and pretty much the entire world is located in the southern part of Botswana, and is called the Jorem Diamond Mine. Beef. Botswana has one of the best beef. I can assure you that. And it's also one of the big exporters. So in 2019, Botswana was the 9th largest beef exporter to the European Union. Tourism is also one of the high exports, because Botswana is well known for having some of the best wilderness and wildlife areas on the African continent. As we can see that 38% of the total land in Botswana is devoted to national parks, national reserves, and wildlife management. And in most cases, these areas are unfenced in some areas so that the wildlife can roam free. I have been talking about the attractive and the good things about Botswana, but we also have a health problem in Botswana, because HIV/AIDS is a health problem in Botswana, because Botswana is the 4th highest HIV prevalent in the world after South Africa, Lesotho, Eswatini. So you can see that all the countries that I have mentioned ,380,000 people were living with HIV in Botswana. If we remember the first slide, there are 2.2 million in Botswana. So that makes about 20.3 of the general population living with HIV. So for the reproductive ages, people aged between 15 and 49, the prevalence is a little bit higher at 20.7%. And in that time period of 2019-2020, there were 9,500 new cases of HIV in the country, and 5,000 people died due to HIV/AIDS related conditions. And 82% of people who are living with HIV are on ART. ART is antiretroviral therapy, or what we'll term the HIV medication. So in 2016, there were 360,000 people living with HIV in Botswana, which is a little 20,000 lower than the period of 2019-2020. And the adult HIV prevalence was a little bit higher at 21.9%, and 10,000 were new HIV infections in 2016, and 3,900 people died due to HIV and AIDS. And As compared to the period of 2019-2020, the ART coverage was a little bit higher at 83%. And you would be asking yourself, why am I talking about 2016 when it's about 3-4 years behind 2020? So in 2016, Botswana launched a strategy called Treat All. So Treat All means if you test HIV positive today, it means you can be enrolled in the medication right away. You don't have to wait to be sick or for your CD4 count or your immune system to go lower for you to be enrolled in the medication. So this was done in 2016. Before that, that was not possible. You have to be sick before you can be enrolled in the treatment. So you would wonder why, because Botswana provides this treatment, ART, free of charge to all the people living with HIV in Botswana, regardless whether you are a citizen and foreigners now. In the beginning, it was free for all the citizens, but around 2019, even the foreigners that live with HIV in Botswana could have access to the medication. But Botswana is still affected by HIV, even though we have this free and universal treatment. And another disparity that we see with HIV is that women and young women are more affected by HIV as compared to the males, because 56% of all the people living in Botswana are women. So also, even though ART coverage is successful and wide like that, there's still challenges because it's compromised by low testing rate. There's still low levels of HIV knowledge, and that has kept the prevalence being high. So let me just summarize what I talked about in the previous slide. So when you look on the map in your left, there are two maps there. So the map on the top is the male HIV prevalence, and the one on the bottom is the female. So here, the darker the area, the problem, the lighter the area where there is not much of a problem. So if we look at the legend for the males, the beginning is at 6.1, but if you look at the females, it's that at 12.3. You can already see like the differences. For males, the lowest is 6%, and for the females, the lowest is 12%. So there is that 50% difference. And if you also look at the female map, you can see that high prevalence of women is across all the districts in Botswana. Whether you are in a rural district, you are in an urban district, the prevalence for females is pretty much high as compared to the male ones. The male ones, you would see high prevalence, particularly in areas with high population. And then if you look at on the map on the right, the one that talks about treatment in relation to HIV prevalence. So here, the lighter the color, the problem, the darker the color, the good, right? So if you look at the light areas here, it says that 32% to 35%, meaning that if we have high prevalence, we also expect the high uptake, right? If people are sick, they should be able to take the medication. But we see that that is not the case here, because there's still some districts that have 35% of uptake, even though the medication is free. But if you look at the districts up north, including Okavango Northwest, Chobe, Tutume, and Buteti, you have a 1-to-1 match, where you have districts that have 100% match. So high prevalence, high uptake. So now let's briefly look at the COVID-19 situation in Botswana. So these statistics are as true or accurate as of this Monday, the 15th of February. So total cases in Botswana since the beginning of the pandemic is 24,435. And out of those, 2,270 were the cases of foreigners who voluntarily decided to go back to their countries. So even though they tested in Botswana, they are not here in Botswana. They went back home. So when I talk local, know that I mean like Botswana or communities in Botswana. So local cases, if we exclude the transferred out, we have 22,165. And out of those, 179 people have died from COVID-19. So local recoveries are 20,542. And remember now, recoveries, we mean those who are not infectious anymore too. We count those too. So that gives us the local active cases to be 1,444. And these people are in hospitals, some are in self-isolation at home, some are in other government facilities. So the local tests that have been done inside Botswana within the communities is 541,189. And the tests that have been performed at the borders for people who are trying to enter in Botswana it's at 162,339, giving a total of 703,522 of all the tests that have been done in Botswana since the beginning of the pandemic. Okay, here we have a zonal map. If we remember the slides where I was showing the HIV prevalence by females and the uptake, it was districts or the health districts. Right now, due to COVID-19, we have what we call the COVID-19 zonal map. So the country is divided into 9 zones. So if I am to give into context here, I am in Greater Gaborone zone. So the zone that is on the north, the southeast, and it's light green. So for me to be able to go to another zone, so let's say I want to go to Kalahari zone tomorrow. I cannot go to Kalahari zone without a permit. I have to apply for a permit in order to move to another zone. So what are the timelines since the beginning of this COVID-19 in Botswana? So on your left-hand side would be the dates, and on the right-hand side would be what has been done, or the activities or the measures that have been done. So in March 20th of last year, 2020, schools closed. School here, I refer to all the learning institutions, kindergarten, universities, primary schools, all learning institutions were closed on March the 20th, 2020. On March 24th of 2020, borders were closed and only citizens were allowed to come back into the country, right? We cannot turn away the people of Botswana. And they had to be quarantined for 14 days upon arrival. And remember these 2 days, the March 20th and 24th, we didn't record any cases of COVID-19. We only recorded the first cases of COVID-19 on March 30th, which were the 3 confirmed cases at the Gaborone International Airport, the SSK. On March 31st, the next day, state of public emergency was declared by the president. And then from April 2nd all the way to May 20th, extreme social distancing, which is what lockdown is known as in Botswana, was implemented. So there was a national lockdown. So on May 20th, in order to get out of the national lockdown or the easing out of the national lockdown, there was what we call the zoning strategy, what I talked about in the earlier slide, where in order for you to move from one zone to the next, you would need a permit to do that. So June 13th to 16th, the 3-4 days, only one zone, Greater Gaborone, was on lockdown because the cases were rising in Greater Gaborone. July 31st, Greater Gaborone was put on lockdown again for 2 weeks. because there was contact tracing going on. In order to ease that, a lockdown was implemented. So from March 16 to December 1st. So this was done in phases, beginning March 16 all the way to December 1st. Borders were open. So travelers were now allowed to come into Botswana, but only if they have a negative PCR COVID test taken within the last 72 hours of departure. During festive season, which was December 24th of last year till January 31st of this year, a night curfew was implemented. So it was from 7 p.m. to 4 a.m., no movement around that time. January 3rd of this year, a new variant of COVID-19 reached Botswana from South Africa called the 501.V2 variant. And from February 1st till now, or till February 28th, the night curfew has been extended. And instead of being 7 p.m., it's now 8 p.m. because unlike in the festive season, now people are back at work. So it was increased by an hour, but still the same thing, no movement around this time. So then what are the challenges that have been posed on by trying to do these measures to curb COVID-19? What has it done then on HIV service delivery? So the first thing here, how does it then impact on the HIV preventative measures? We always talk about how prevention is better than cure, right? So in order to minimize HIV testing has to take place. Condom distribution has to take place. There is safe male circumcision. There are other programs that are related to HIV that the government has impacted on. But during a lockdown, so I'll be specific on these challenges to particularly the lockdown season. So we saw HIV testing becoming so low. One other reason was HIV testing was not considered an essential activity. You remember, for people to move out of their houses, they would need a permit. So in order to get a permit at the beginning, the online permit were not as widely distributed as they are now. People didn't have much access to apply for permits online. So they would have to go to a district commissioner's office or principal's office at a school or at a khotla. Khotla is a traditional court here in Botswana. So you would have to go there and queue up, and there were only like a few permits that are allocated on that day. So let's say they would distribute 40. So if you come as number 41 or 45, that means you are not going to get a permit on that day. You have to go and try again tomorrow. And even if you going to go to the magistrate and tell them that you need a permit to go test for HIV, they will tell you that it could wait. It was not as essential. And some of the funds that were dedicated to provide free testing were diverted now to COVID-19 because it was an emergency. Condom distribution also became low because the suppliers of condoms are mainly from outside. So borders were closed and supplies could not reach the country. So the safe male circumcision is a campaign that is done for males who are not HIV infected in order to try and prevent HIV or reduce the transmission, because research shows that safe male circumcision can prevent HIV about transmission by about 60%. So during this time, the campaign did not go on. So also orphans that are due to HIV, they have programs that are supported by the government. They will do visitations, they will give them support group. These were not possible during this time. Another challenge is on the impact of HIV treatment, which I said is the ART or ARVs. So there were minimal operation of the ART clinics that led into treatment non-adherence. Let me just give a little background of how one is enrolled in the treatment or what a treatment entails in Botswana. So let's take a scenario, somebody tests today positive for HIV. They would have to be registered at a particular clinic. So let's say there are 10 clinics in Gaborone and you choose that you're going to be registered in clinic 1. You're going to be in clinic 1 for the rest of your life. That's where you take your medication, that's where you see the doctor and do all the blood work in order to monitor how the pills are taking you, right? So during this lockdown, not all these clinics were open, and also transport was not much available. So public transport here in Botswana is run by the private sector. It's not a government entity. So because everything was halted, people could not even go to these clinics that were open at that time. Even to go outside your house, like I said, you had to get a permit. So think of it, you go to the magistrate and you are late for that day, they've given the 40 and you are number 45, going back to the last example. That means you would have to come and queue up again for that permit. And if you don't get, that can deter you to go to the clinic. Then the direct impacts brought by COVID-19 on HIV prevalence. So unemployment became rampant. So here I have the statistics that I would want to put this in context. So unemployment in Botswana is pretty much a problem because it's at about 20%. So then during COVID-19 or during the lockdown, that accelerated because most of the families and communities here in Botswana rely much on the informal sector. So informal sector brings about 5.3% of the annual GDP here in Botswana. And more so, women make about 88% of the informal sector workers. In addition, women make 77% of people who work in hotels and restaurants. And lockdown was between April and May. So around that time, that's where is the peak season of tourism here in Botswana, because the temperatures are cooler, because that's when we start experiencing our winter here. The Northern Hemisphere experiences summer, so they would come here for tourism. So at this time, all of this were closed. Families and communities rely on activities that are brought by tourism. Could be boat cruise. They operate the flights where people see Okavango Delta from above, and then there's the weaving, the beading. They could not go outside their houses to be able to render their services. So that meant people had to stay home. And when people stayed home, there were also no weddings. Weddings are also very important occasions here in Botswana. If there is a wedding, more people are going to benefit from it. People have to design the bridesmaid dresses, and they're designed locally. So you have women who would be tailoring that. It's not that we don't have the men, but a lot is the women who do that. There are catering companies. There are, you name it, right? And then all of this were not possible during this time. Schools were closed. People sell around the school gates. They sell candy, they sell phone airtimes and food to the school going kids. And also children use public transport to get to their school. So public transport schools were closed, it couldn't run. So that escalated the unemployment. Most people are renters, so they faced eviction. So new HIV infections increased, and I am basing this much on the assumptions because HIV testing, if you remember, was not treated as an essential need during this time. So they grew because there were no jobs and most people were trapped at home most of the time with their abusers. And if we remember the other part where we said condoms were not as readily available, people had to go to the clinics to get condoms. So you can imagine a situation if somebody goes to the magistrate and say, oh, I need a permit for me to go get a condom. Okay, that might not be a need that would be given that much urgency. And also the ability to buy condoms, if you could afford to buy condoms, if you didn't have a job, and there are many things that you would put as a priority than condoms. So that's why the assumption of unprotected sex increased. And then a little bit here to talk about the GBV, so gender-based violence cases. So the Botswana police, from March 30th of 2020 to April 5th of 2020, there were 22 rape cases, which was an increase of 6%. And out of those 22, 7 were children aged between 2 to 13. And there were 23 defilement cases, 2 murder cases, and these murder cases were involving couples. So what have been the interventions that have been done or that are still ongoing in order to address this problem? So the first part on the ARV medications. Now after lockdowns, more clinics are operating and people can go to closer clinics or the clinics that they are used to. Remember, with HIV, there's also the stigma. So if people are not going, they're going to the clinics that they are not usually going to or registered to, people are like the gossiping about, oh, he is on the medication, he has 1, 2, 3, 4, 5. So more clinics are operating and are closer. So also there have been home delivery of ARV drugs. So notice this, for the home delivery of drugs, this strategy has been done in some clinic or in some areas, only in the capital city here of Gaborone. And it's only done with the people that are adherent, meaning those that do not miss their pills, so they're taken to be more responsible. So they can be brought to the pills at anywhere they are at, whether it's their workplace or it's at their home. So what has been done or what's being done about unemployment? So in mid-April, so during that lockdown period, the government launched what is called the COVID-19 Food Relief Program, and 150 million pula was set aside in order to provide for food for families. So during that time, around 45,000 households were assessed and helped. Also, people who could not pay their water bills, they got their water reconnected without any fees. So during lockdown, and also it's still going now because we are still on state of emergency. So people cannot have their water cut. Another thing is small businesses, where we talked about how the informal sector is made out of this small businesses. They are still being assisted with 1,000 pula, which is about $100 to be able to kickstart their business that have died due to COVID-19. The government, the banks on the private sector have also stipulated a 3-month no interest for repayment. And then on the GBV, gender-based violence. Oh, why can't I say this word? The Botswana GBV Support Center has been assisting people, women and children in particular, with shelter and food. And they have also established hotline services where the victims can call for free and with privacy. They've also opened extra shelters, temporary shelters, where they can accommodate the victims. And then key populations such as the sex workers have been and are still being provided with masks and condoms. And also the NGOs are using technology, particularly social media, to connect with sex workers in order to set appointment for their refills if they're HIV positive, to get their ARVs, STI screening, and to also have access to their psychosocial support services. That's the end of my presentation. presentation. If you have any questions or comments, thank you.
Thank you so much, Dr. Mati, for such an enlightening talk.
Thank you.
Welcome questions. I'll quickly check in the chat. If anybody has a question now, you can either put up your hand or go ahead and unmute and ask the question.
I have a quick question. Hi, Natty. This is Amal speaking. I am studying
Hey,
human
Amal.
rights at the University of Edinburgh. Hi, everybody. Matty, you mentioned a lot of the different things that the Botswana government is doing to assist people. I mean, I think it's a good start, but where do you think that they could improve, especially since you mentioned, for example, the banks giving people 3 months, like, and they don't have to pay off loans with interest, but what more could be done? Because I don't really think that's enough, but maybe also, like, you're in Botswana, you can tell us if it is actually enough and what else is.
All right, Amal. Okay, do you want me to answer right away or wait for more questions?
I think let's hand a question at a time so that we.
Okay, all right. Thank you, Amal, for your question. What I have seen here, particularly in Botswana, is we tend to pay too much attention to what we can give people as goods or handouts or things that are tangible that people can be able to access, like what the government has been doing by providing free food. But one thing that COVID has really brought in about is the depression or the mental health. I feel that area really has not been taken much care into. Like, the government has not done much, or even like the civil societies or other NGOs have not put so much effort into that. Because think of if somebody has been having this good job and they have been able to provide for their family, and now they are sitting at home and they have kids and they have a wife, particularly if you are a man and you know that you have been providing for your family. All these thoughts that, particularly here in our Setswana culture, where we know a man is a man because they can provide. But right now you are sitting at home, you are sleeping, and most of the people, alcohol has been banned too, just try to curb the spread. So people usually would drain their sorrows, if I'm to call them sorrows, with alcohol. They could go to bars and like unwind. So now you are here at home, there's no alcohol, you have these bills and all of that. So much can be done to improve the mental health. Really, that has been an area that I feel has been neglected.
Maddie, this is Amara. Thank you so much for a great talk. I wrote a question, but I wanted to just clarify it. I just loved how much data you presented on the number of tests that has been done, what those that are out of the area, positive testers, etc. I wondered if you happen to know, I did a quick calculation from your slide, and it seems like given the total tests you've done and the positivity, that there's about 3.15% positivity, COVID positivity rate overall. And the number is not as important as the whether understanding, at least to me, whether HIV positive individuals are having rates of COVID positivity that is different from that 3.15%, and any detail about who's testing positive for COVID in Botswana. Any kind of insight on that?
Okay, maybe let me see if I've got the question. So it's more, you are asking more about in relation to those who are HIV positive. Are they also
more likely
COVID
to test?
too?
Yeah, exactly. Are they more likely to get?
Oh, okay, all right. I don't have like concrete like statistics or data on that, but what I have read or what I have heard on the TV is that, like, they, from the testing that they have done, they haven't seen that HIV positive people have much vulnerability, like they are testing as much COVID positive than any other group, but particularly it's people who have other chronic diseases such as diabetes and high blood pressure. So that's where most of the deaths that have been happening would be somebody has tested COVID-19 positive and they either have diabetes or they have high blood pressure. But for HIV, those ones I have not got that much difference on that.
Yeah, that is very interesting, Marty, because I really like the question from Tamara, because one of the concerns about COVID-19 was the likely impact it's going to have on individuals that have a compromised immune functioning,
right?
Immunity. So, and I think it would be interesting from your point of view, because I know you are an HIV/AIDS researcher as well. I mean, that's one of the things that we're doing while we're here. It would be interesting to monitor the mortality relative to chronic diseases, NCDs, as well as an infectious disease like HIV/AIDS, which is a major issue in Southern Africa. So I think it would be very interesting to keep an eye on that and look at the data, and even advise government to keep an eye on that to see what kinds of mitigation strategies could be put in place to address that. I really enjoyed your presentation, and I think the mortality rate from COVID is still not yet overwhelming for the continent, but I'm very concerned about the rollout of all of the vaccines in the continent. The data today shows that there's an article from Nature Today Science that shows that Africa is yet to start vaccinating. I mean, there are stories here and there of Sputnik and AstraZeneca in South Africa, but it's very clear that because Europe and the United States and other parts of the developed world are thinking about their populations first, and that makes sense. What is the situation in Africa? What are the plans, and how is that going to impact Africa? This is the reason is that my concern with this is while the mortality rate might be low and the infection rates might also be low, and the countries have these powerful mitigators. I really love zoning in Botswana. I think it's a very good strategy to deal with the virus. But the impact is going to be huge if no vaccines are actually available within the shortest period of time. So any thoughts about that?
Say that last part again. I did not hear that part, and say it a little bit louder. I'm sorry.
Yeah. Oh, I realized I had this closed. I was saying I don't know what the impact is going to be with the late rollout of the vaccine when Africa is so left behind, and of course because of the dependency on Europe and the United States in terms of development of the vaccine and rolling out the vaccine. So the danger for Africa is not in the strategies that they're doing, but rather in the rollout of the vaccines and what the impact is going to be on the continent as the vaccine gets more and more delayed because of the dependency on the West anyway.
Right. So I didn't know that was a question or that was your observation.
It's my observation, but I was just thinking what your thinking is, because
I mean, okay, what
academic,
are my thoughts about?
Yeah, you're an academic COVID, and I think you can make impressions to the health systems.
Right. Oh, okay. All right. Now that you talk about that, because I remember, like, when you talk about the dependency in the Western medication, here at University of Botswana, there was one professor who was working with the traditional doctors, professor here, but he was working with the traditional doctors because for some other diseases here in Botswana, we have always relied on traditional doctors to help in them. But it was an idea like people just took it as an idea. Like there was not much effort that was put on it. It was just like, oh, there is a professor at the University of Botswana and he wants to work with the doctors, and that was that. It was on TV, but there was like never a follow-up on that. And more efforts have been like, we have spent so much money in order to secure a place with AstraZeneca or whatever vaccine that we are going to have. My point here is that there are things that we could do here in Africa, but we are putting so much reliance on the Western side. I'm going to like also connect it with HIV. In order for the HIV strategy to be as successful as it is in Botswana, is because all the stakeholders have been involved, whether we talk about the church, whether we talk of the traditional doctors, because the communities here in Botswana really believe in these activities in their communities. If a chief is going to stand up and tell people or talk freely about HIV, people are going to listen more than if, let's say, it's a nurse. They would feel that if our chief can talk about that, he's just like somebody that we live in with the community and he can encourage us to do that, because people still also use traditional doctors. It might not be out in the open, but they use traditional doctors. So I was thinking if we could have implied the same system into dealing with COVID-19, we might not be as where we are at. We might not be at the very like dangerous situation compared to other countries, but we could have just involved the other stakeholders more. I don't know if that answers a little bit of your concern.
Yeah, yes, it does actually. The point is that a very elaborate primary healthcare system is helping, and to see that the zones that you're presenting with HIV/AIDS and the clinics where people have to be seems to be the bedrock of the COVID-19 response. So that's right. Interesting to see. Yeah.
Mm-hmm.
Thank you.
Thank you so much. Don't mind me, it's very hot. I'm so sorry, it's really hot.
Do we have anybody else with a, I think Josie asks, what's the status of vaccine distribution?
Oh yeah, I was actually anticipating that question. So every week here in Botswana, every Monday and Thursday, there's what we call the COVID-19. So the presidential task force comes in and talk about what is the situation about COVID-19 and the vaccine. So today, actually at 6 p.m., while I was rehearsing for this, they were talking about the vaccine, how it's going to be distributed, when it's arriving. So vaccine has not arrived yet in Botswana, and we are anticipating it to come about the end of this month and beginning of March. And there are going to be 3 phases how it's going to be administered. So the first group would be the frontline workers, obviously the doctors, the police, the army too. And then the second phase is going to be elderly and people with chronic diseases such as diabetes and high blood pressure. And then the third group would be vision. And initially, when the government was talking about the vaccine, they said they're only going to vaccinate 20% of the population. Right now that the vaccination is coming, they're saying that everybody is going to be vaccinated. And that exercise is going to be happening throughout till December of this year. So by Christmas, they assures that everybody would have been vaccinated in Botswana.
Perfect. Thank you so much.
Okay, I have a quick question, Dr. Kelepile. I know I'm pronouncing it wrong, but I'm taking you back to the point where you made about the treat all strategy. I believe that's what you call it. And I think it's a really one of the best ways of preventing, like a preventive measure. But I wonder how open are people to voluntarily going for testing? Because I know stigmatization is one thing that makes people hesitant to just volunteer to go and test before they feel sick or they get sick. I was just wondering, how does it work? How do people just show up, or what's the strategy to have them get tested before they feel sick?
Okay, so one thing is when you are pregnant, you would have to register with a clinic, right? So all the pregnant women in Botswana, HIV testing is mandatory. So those ones, no questions, you would be tested. And then what about the population? How do you get the population to go test? So when you go to any public clinic in Botswana, testing is not like mandatory, but that would be the first thing that they would ask. Even if you come and say, oh, I have flu symptoms or I don't feel well, the first question they will say, have you tested for HIV? The caravan is outside, the porta cans are outside. That is a public clinic. There's always going to be, they call them the community mobilizers. They're just going to be around people who are queuing, and they will be asking the questions like, have you tested for HIV? It will take only 15 minutes. And one other thing is, before you could test, it was required that you have an ID card called the Umang here in Botswana. Now the strategy that they saw is that they would ask people if they want to test, and people would use that excuse and say, I didn't bring my Umang or my ID. So in a way to escape. So now in order to encourage more people to test, they will say, even if you don't have your Umang, it's just gonna take 15 minutes and that. So they try to, like, for any disease that you come to complaining at the clinic, that would be the first question that they would ask.
That's wonderful. Thank you so much.
You're welcome.
Thank you everybody for the questions. I'll just check the chat once more. And please everybody always check the chat window as well. There is always comments and other things on there that may be of interest to you. Since there seems to be no other questions, I'll just say another round of thank you to Dr. Mati, and then we'll move on to Dr. Jorem Awadu.
Tutilo, there's a question on there.
Oh, let me check. Did I miss something?
The very last
had a
one.
question.
Oh, I might have missed it. Oh, okay. I'll read it for you. And it says, I was a bit late to the discussion and also cannot talk because I'm at work, but I've heard you talk about HIV positive sex workers and how COVID has affected their medication uptake. I am interested to know how COVID has actually affected sex work and whether you are now seeing more sex workers testing positive, HIV positive, because of more risky behaviors due to the lockdown.
Okay, that's actually a very interesting question. So if I put it in context here, sex work in Botswana is happening, but it's illegal, right? So people are practicing sex work, but it's illegal to do that. So that means already the sex workers have problems to be able to access most services. So here, how have COVID-19 impacted sex work, and have we seen high HIV cases among them? So if we take it to the lockdown period, and then I'll talk about the period now where we are dealing with the curfew. So the lockdown period, remember, people did not have much access to get out of their homes. You would need a permit to get outside the house. So during that time, sex work was not easily, like people, sex work most of the time, it will be around bars and people would pick the sex workers like around those spots. So during that, it will only be people who were regular clients, so who would where these people are located. So then business was not as you can talk through the phone, right? So then let's go to the situation now where we are not in lockdown, but 4 a.m. you should be at home. So, and during that time, the night time, that's when the business it's supposed to be good for the sex workers. So that makes business die that way than they had it before. But there are still right? So what about the services? How do sex workers then receive the HIV testing or treatments? It's mostly like the sex workers, most of them are registered with these NGOs. The NGOs would have the registers of them, and those are the people that make sure that they get to their HIV medication and also bring condoms to them if needed be. So I don't know much about the testing through this period, but in overall sense, when you look at the general population prevalence, the prevalence for the general population is about 20%. But the latest that I found, it was for 2019 and beginning of 2020, the prevalence for the sex workers was at 62%. And it went up from 42% in 2018. So I would not know if this 2020 first quarter then really reflects what was during like the COVID-19 situation. So I am not really like much informed on that part. So I will need to look more into that one.
Okay, thank you so much again, Doctor. And
Thank you.
if there is nothing pressing now, you can always actually have another question after the next presentation.
Okay.
We will move next. Somebody says something. Okay. Jorem, Dr. Jorem Awadu will have the next presentation, and his talk, for those who are just joining us, is titled Autism Assessment and Rehabilitation, a Tale of Unmet Parental Needs in Uganda. You're most welcome, Dr. Awadu.
Thank you, Dr. Tutilo, Mudumba. It's such a pleasure to actually be here today. I wanted to start this off with a short video. I don't know, Dr. Damaris Choti, do we have that?
Yes, I'm gonna show it right now. Can everyone see it?
Sure, I can't see it.
Okay, let me go back and then, okay, there you go.
At first, everything about Abby Kamau's baby girl seemed normal. She met every development milestone and delighted in every discovery. But at around 3 months, Faith Kamau was given an expired vaccination in which she was the only survivor out of all the children who got the deadly jab. She started regressing, and by age 2, she had fully retreated into her own world. She no longer made eye contact, nor seemed to hear. The trips in and out of various hospitals for the past 22 years has been countless.
That is when she was given an expired vaccination, and the children who were vaccinated with her then, most of them died. So since then, I've been in and out of hospital. She was like just a baby born child. She had not gained strength even to sit, or even the neck had not held. So this happened at 4 years. This is when she was able to sit. She walked at 8 years.
Abby is at pains trying to explain to us how the journey has been and the friendship the condition of her only daughters cost her. But she says that prayers, her husband, her colleagues, and her closest family members have been supportive.
So most of them, they are never there for me. But there are others who are loyal. Most people don't want to be near me because she's screaming, and even the house girls, those who have not had such an experience, they just can't stand it. It's like a drama, everybody is standing to you like this is not a human being.
But she's optimistic that her daughter who loves singing will be able to defend on herself someday.
How excellent is your name. How excellent is your name.
Jane Womboi's case is quite different for her only son Alvin, who has a less serious case as compared to Faith, and has even been integrated into a normal public school. But she is quick to point out that the sea was rough before it settled.
They have already integrated him into the regular school. The special needs teachers take care of him as he is in the other regular school.
But Womboi's biggest fear for Alvin is her future when she will not be around. Alvin is focused on being a pilot when he becomes older, albeit hiccups.
My biggest fear is, what about that day when I will not be there? What will happen to my son?
God will punish them. What they did to me, what they call me names, they will be punished with God.
Autism is a brain disorder whose symptoms gradually begin after the age of 6 months, become established by age 2 or 3 years, and tend to continue through adulthood, although often in more muted form.
A condition where children are not able to interact with their environment. They are not social, so they don't have the social skills. You begin to communicate in other languages, the language of touch, the language of love, hugs, the language of drawing, coloring.
There is no cure for autism, though with early interventions and treatment, the symptoms can be greatly improved. Children with autism spectrum disorder may have restrictive and ritualistic behaviors that affect their eating habits.
They tend to be very hyperactive sometimes. Yeah, and so some of the sugar, the food that leads more to or tends more to very sugary foods that are high in gluten, so things that are very high in wheat content, we tend to lower that. And that is to help them have a healthy gut microbial system, so healthy gut flora, that's what we call it.
Felma School alongside Wayaki Way in Westland, Nairobi County celebrated 30 years since it opened doors to children with autism and other related development difficulties by having a 10 kilometers walk. But as Fan Eshuchi, the founder, explains, the journey has not been easy.
The 30 years have been a journey. And we have actually been able to see God's hand in everything we are doing. Yeah, when I started, I didn't know whether I was doing the right thing or not.
The participants and volunteers were not left behind as they came out to help the needy challenged children.
It's brought people together, people from very far And it's amazing what people can do for the, special kids and all. Yeah. It's been good, but okay, it's also tiring, but I think it's really worth it.
Time that we've been doing these charity walks, so it's something that is in us. We try to help where we can.
I came with my daughter last year, and this year I brought my whole family.
Fund gives hope to the parents that they should brace themselves and look for help and not hold their children in the houses.
And they should not hide them. They should be encouraged and bring them to schools and take them to hospitals. We have kind people, and God will see us through.
Appreciating that child, you accept that that child has that condition, and you walk the journey. And the journey is therapy, diet, love, and all will be well.
What the parent needs to do is to brace themselves, look for help. The help may come directly from a doctor, from an occupational therapist. It may come from an educationist like me. What they need to do is go out and purposefully look for the help.
In Kenya, there are about 2.3 million school-going children with special needs, but the few number of special schools totaling 200 countrywide, lack of special teachers and inadequate funding have been major challenges, and even 10 million that Nairobi County set aside for these is not really enough.
Aside 10 million shillings to cater for people with special needs, and the reason why we didn't set aside a lot of money, it's because we didn't have an act in place.
It is expensive, so most schools shy away from that. And then also teachers who are trained in special needs are not as many as the requirement. So you find that we have just one KISE, that is the Kenya Institute of Special Needs, that trains teachers, and most teachers who go are the ones already in service.
Diagnosing autism spectrum disorder can be difficult since there is no medical test like a blood test to diagnose the disorder, forcing doctors to look at the child's behavior and development to make a diagnosis.
FEMA School, in conjunction with the Nairobi County government, believes that autism is a condition that can only be managed by having a proper diet and medication for their patients. Ouma Onyango, KUTV, Nairobi.
Thank you, Dr. Maris there. And let's see where we want to go with this now. All right, so again, thank you. I share that video majorly because I think most of the perceptions people have about autism or the cases they see are the extreme ones. But like, most of you here are aware that, it's a spectrum and happens, has different presentations. And most of the children would see in the clinic are actually those that are low functioning, in most of these areas. And so the parents are so concerned, but others could just, get lost into the system. And I showed the Kenyan video because, it was the one that it kind of portrayed much of what I've seen. And my journey with autism started in Nairobi with, Gertrude Children's Hospital in Muthaiga, where I was interfacing with mothers that you did see about the challenges, that they do experience. And I felt touched by their story and everything that they go through. And I felt that, something could be done about this. So I will be referring to a couple of, things in there. At diagnosis. So having lots of information from different sources that actually see this child is better than having it from one source. We do know that about 80%, it is genetic, in nature, but we do have some research out there too that seems to say that environmental factors. We did hear about vaccines in the video and all of that, but most of that is really work that needs a lot of research going on, but at least we do know that the genetics are the biggest part of it. So hearing about the expired vaccines and all of this is not something that is new, and you've had it even now that we are going through the pandemic. There are lots of anti-vaxxers everywhere, but you can imagine what goes on in a parent's child as they keep blaming themselves for causing this. Maybe if I hadn't taken the child for vaccination, or if I hadn't done certain things, my child will be well, and this is a lifetime condition. We do know that autism, it's estimated that at least 1% of individuals have ASD worldwide, and in Africa the picture is not yet as clear. But in Uganda, it has been put at about 1.2 to 1.3 of every 100 children. But again, this was the research that were didn't set out to really establish a prevalence. It kind of stretched a little bit into trying to project, and so very few studies have actually been done on projecting what the picture is in Africa. And we do believe that actually it could be the same picture as we see, everywhere else in the developed world, where a lot of work has gone on. On the continent, I remember, I keep sharing this map. Much of the autism work has really come from South Africa, let's say publications. There's a lot in South Africa and, the West African coast, especially from Nigeria itself. When you look at East Africa, where I am focusing on today, especially Uganda, not much has been done. That's not to say there's no work going on in there, but I think the interest of researchers therein hasn't yet picked up. And so, the study that I did show, I will be showing you is one by Dr. Angelina Kako's a psychiatrist, consultant psychiatrist within Mulago Hospital, in Uganda. So when I looked at this map and I looked at the research, and there was nothing much. Having been to Nairobi, talk to those mothers and all of that, this was just a natural go-to, especially because I tend to gravitate a lot towards mothers, and I don't know why, but mothers and their suffering and pain. I think it is because of the influence of my mom anyway, but that will be for another day. But yes, I tend to, this, disability and all of that are areas that are really, really so close to my heart. And so I decided that, we would do something about it. So when you compare Africa to the other, continents, sub-Saharan Africa compared to, other continents therein, you can see how we are faring in terms of research in this area. And so there's a lot of room, for researchers that are interested, whether it's from education, health sciences, behavioral science, any of those there. I think there's a lot of room for us to contribute some knowledge and help our people therein. So that is what pushed me, and I've shared a lot about this study with I think this team again. Damaris, if you remember, at a certain point, I did talk about this, and I just submitted this to a journal this afternoon. But just to do a recap, that what you did here in that video is everything that I did see in the parents in Uganda. And again, these were high SES mothers, because I at times wonder what happens to the children whose mothers can't afford to go to, such expensive special needs schools. And these are children that are basically left in the backyard, probably. And, lots of experiments are performed on them but they're just closed to the society. We don't know what's going on. And those are the people that push me to kind of, do this work that, how do we help those people that cannot access the services? Because if you have had autism, has been referred to as a disease for the rich, like they call it a disease. But this is an unequal affliction, disorder that doesn't choose whether you're rich or not. But we only probably see most of the rich because they're the ones who are able to get the specialists who are actually putting a diagnosis or a name to, this thing that is disturbing their children. They're the people who will access in the schools and everything. But social stigma is a big one. We did hear it in the video where they're blaming you for everything. You wanted to get rich, so you sacrifice the child. There's something you didn't do right. You have to repent. You have to, atone for your sins, and all of that. Like the support you did here, the mother again say in that there are people who will support you, there are those who are not. Doesn't matter whether you were a family member or not. Family members were disinviting, their sisters who are sisters or brothers as a result of having a child who is very hyperactive and they don't want their places messed up. So if you're coming for a party, probably leave that child behind, I would appreciate it. And so all those kind of, things going on. Financially, the burden is so heavy. Like I did say, most of the schools, for the Ugandan schools, for example, centers I went to, these parents were paying not less than 3 million Ugandan shillings full term, and a full term is about 3 months. So you pay that 3 times a year. That is more than what some other individuals used to pay for education, the tuition in higher institutions of learning. And so you really have to be in a position to afford it. Otherwise, then the situation is that the broken marriages as a result of the financial pressures that come with it, and a lot of expenditure, very little improvement in the child. How do we continue with this? And a lot of that, mothers were giving up jobs, and then it has to fall on only the father to go out, simply because, like you did here in the video as well, the house helps, that can't help us with the houses on seeing a child basically are trying to leave as soon as they can, because they say it's too much. Unless you pay them highly, will they stay? So some of those things are the bigger ones. And yet we do see that some of these children, especially the low functioning, really needed basic living skills. Like you do know, language in most of the low functioning is really affected, that they cannot communicate. And so most of them would pull you to whatever they want. And that was a big challenge. The issues just around awareness: how safe am I running onto roads, with the heavy traffic, and all of that. Those are all concerns. And like you did hear the mother say, really, how will this child survive? One of the caregivers told me, if I'm gone, how will this child survive? I wish when I die, this child just goes with me, because I don't trust the society will treat them, fairly, because it's only me that understands my child. So really, there is that fear of the future for the child, because they can't, the low functioning type wouldn't cook for themselves, and probably without a lot of rehabilitation efforts, just basic activities of daily living would be very, very difficult. And so that would be a burden to lots of people. And so most of the parents, as a way, which stood out, not to say it's only in Africa, the physical discipline as an aspect stood out. Some mothers were actually using physical discipline. And I say, well, if you've grown up on the continent or have been raised by, an African mother, I don't know about this. Happens everywhere, but physical discipline had to be used at certain times. And so now the physical abuse, and all this discipline, like, where is that line, especially with a child who cannot communicate their needs? And so some mothers feeling like they get frustrated, and that's all they need to do to kind of help this child get the connection, that you can't keep turning the tap on and the water is flowing in the house. It's wasteful and things like that. But other than that, there was resilience. Mothers felt this was a blessing. The disability disorder was a blessing, and that who else would have handled such a situation? The Lord put this child into their lives simply because they could handle, and so they would talk to other mothers and find the joy. And so part of the video as well is to raise awareness for the disability. that, you know, these children are there in varying categories and, you know, asking questions like, oh, how terrible is the situation in Africa? In my view, in this field, I see this situation as often as, you know, one would see in clinics in here. So it is there. The problem is that we do have few specialists who can actually recognize it, you know, from the word go, especially if you're not visiting a national referral hospital with some of the specialists, you know, therein. It will take somebody who has, you know, to kind of point you to the right direction. So this is a critical because I was trying to investigate what is there in terms of the screening efforts or diagnosis efforts in Africa. And this was the only attempt that I did get at, you know, Dr. Angelina Kakoza trying to, you know, get the 10 questions questionnaire, modify it in such a way that, you know, as a team, they would be in position to get as many children with different neurodevelopmental disabilities and then try to assess them further. And so some of the children suspected of autism were also found as a result of this because they had 10 questions dedicated to trying to get autism within the community. And so this, to me, was you know, such a good effort. It was the only one that I really had come across, although they'd set out to just adapt the 10 questions. I think they did so well in setting the tone for their work in autism screening. And so I took interest in that. And I decided to investigate some psychometric properties of other instruments, plus what they did use, you know, which is this one. So I got the 10 items of the 23Q and, you know, looked at a social responsiveness scale, second edition social communication questionnaire as well amongst these children. And, you know, administered it to children in Uganda, to the mothers of these children in Uganda. And so, again, in my thinking, in my reasoning, without deliberate efforts for us to actually identify these children, then their adulthood is kind of, you know, not going to be as good, because we do know early rehabilitation efforts really better the chances of these children managing and, you know, being successful later in life. So this is what drove me into having that. And so we looked at those, and this, I put it here just to kind of show us what some of these questions are. The yes or no type questions that then at the end of the day, you get to have the totals, you know, following a certain algorithm. And you do know that, okay, for this social communication questionnaire, if a child got 15 or above in terms of their total score, then there's a high likelihood that they could have autism. So we need to refer them. The social responsiveness scale is the same. Here, 65 items. And we do know that, okay, if you're in the community and a child scores 70 or more scores, you know, scores more or 70 in terms of, you know, the totals therein, then we have to refer that child up. If it is in a clinical setup where already somebody might have suspected autism and you're administering, then we would give them, you know, a threshold of 85, you know, to kind of, you know, then say, hey, it's conclusive. I've been, you know, some at times colleagues from Uganda send me some of their records, and, you know, we go back and forth in terms of arguments, you know, saying, well, I think you need to visit this child before you actually give, you know, this label. You need to see the child physically, because yes, this is what the mother scored and sent you or the father. But I do believe having multiple sources, a teacher, and you yourself observing this child would be good, because there are lots of comorbidities that would come with autism that reduce. Intellectual disability is one of them. There's a lot of, you know, attention deficit hyperactivity, you know, disorder in there. The issues around epilepsy and, you know, lots of other disorders. So really differentiating and placing the child in the right, you know, kind of category is a thing that takes practice, is a thing that, you know, takes a professional that really cares. And I've found mothers who are clinical psychologists in this boat who have also taken it up now as a, you know, their area, because they're clinical psychologists in training and they've taken interest in this. And so most of those would take a lot of time before they actually give this label, because they are living this at home as well. And, you know, they kind of see, they're sensitized to some of these mannerisms. But I was very interested in the 23 question screener because this was set in Luganda, which is one of the local languages we speak in there. Its scoring was a little unique, as well. Mothers easily understood it, and I really wanted to see how it performed. So I gave those. Somebody would say, why would you go with those again? These do not require a lot of advanced training like we do see psychiatry level and all of that. This could be administered in the villages where not so many college level trained physicians could be. This could be clinical officers, this could be nurses, or that could actually administer this if they saw a case that they suspected that it could be even a social worker. If they saw a case that they suspected to be this, and the mother can respond to these questions, they could be in position to let them know you need to see the specialist. So that is why I was moved to go with this. So you administer it direct to the parents or any other primary caregiver, spending a lot of time with the child, and they had both the social communication questionnaire and social responsiveness scale have a very strong reliability and validity based on the research studies in the US. And so they are actually used, out here as a good screening tool. So having those, was really a good way to kind of start this work, because either way, they're matched to the DSM, Dynamic Statistical Manual, which is really the biggest kind of it's the biggest assessment tool for all the professionals, back home and all over the world. And so matching it to those categories, was a good thing. So let's see. Basically what I did, I'll describe this and, not to run overboard. I basically modified some of the items of the mothers. After giving a pilot, I modified some of the items to suit the culture. So what you see on the red, on your, depending on how you see it, the red are some of the modifications I made, and the original item is what would be in blue, on the other side. So if you say, for example, traffic lights, drain pipes or timetables, this may not make sense to a mother. If you say hot rain for steam or, some of these, they may not make, a lot of sense. But so just changing them a little bit to kind of make sense to a mother for the SCQ was what I was doing. And the same was done for the social responsiveness, scale. So I altered those a bit, but these, I now have close to 200 of these children, but I used just half of these earlier on. And so there were two groups: caregivers of children aged 4 to 18 who had a confirmed diagnosis from a psychiatrist or any of the other professionals that diagnose in Uganda, and then group 2 who were typically or controls, in the community within school that didn't have, any history of a developmental disability based on the history taking, that we actually did at evaluation. So we did compare those, and we did have 51 in the autism category and 56 in the non-autism category. And so I played this table specifically because today I didn't want to deal a lot in numbers. I want to tell a story about this. But the major thing I wanted, to show here was that we do know that we can now have a child diagnosed with autism at 2.5 or even younger, in some of the developed countries. But overall, we do know that by 4 years, most of the children should have gotten a diagnosis if they see professionals at least. And so, looking at the children I did find, you do see that actually most of them, their mean age at first diagnosis was 4.1 years. But also what you do see here, and this is an argument I keep making, is that a psychiatric clinical officer, not as trained, at a college level, most of them a branch of nursing that then, they have to specialize in, in the psychiatry elements of the training. And so there are so many of those in the community. And you could see that, gauging from the records, gauging from a panel that was not only medical doctors, but that you had quite a sizable percentage of diagnosis from these psychiatric clinical officers. You did have others. In the other section, we did have occupational therapists, and I did combine some of the special needs teachers as well therein, mostly at the child development centers. And you could see clinical psychologists are also doing, quite a job. And I argue that I think more effort has to be pushed into this low level. I don't want to call them low level, because here they say you have a PhD plus to actually diagnose, a child. But I argue that we probably don't need that for Africa right now. We just need people who are exposed to the circumstances, condition, and can actually diagnose and refer these children for rehabilitation. Because I met parents whose children diagnosed at 9 years, 9, 10. That is you're kind of far off in terms of the remediation benefits that would actually, get language and, all of that. So speech language therapists diagnosed, a lot of these children. They're also, in here. So that's an argument, I wanted to kind of, show in here that, these, trainings, a 1 year, 2 year in this area still, do. So let's look a little around the outcomes of these instruments. So, and again, I was organizing it as a story. Let's see. So when we see reliability, just looking at the children with autism alone, or the confirmed diagnosis, according to the research, other people had utilized these instruments elsewhere, and the manual itself, most of them had a reliability of at least 0.80, could catch about 80% of the children with autism. And so that's what I based on to kind of project and say, we will have a reliability of about 0.8, 0 amongst children with autism. But for the SCQ and for the SRS, probably 0.90 will identify about 9 out of every 10 of these children who actually have autism. This a little fell short, but this is not to say it is so bad. So you can imagine if this one is identifying 8 of every 10 children with autism, I think that is good. 6 is a little wanting, but remember, they have different CAT scores. The SCQ has a CAT score 15, like I'd said earlier on. And so those are some of the questions we're asking. Does that score apply to the Ugandan children, the Ugandan culture, all of this? So this, when we do, I'm jumping ahead of myself and but let me compose myself a little bit here. So they fell short a little bit, but look at the 23Q, which was again Dr. Kakoza's work in Molago, with this. So when I try that, they say administer 10 items to these, children, but they break them into 5 for children who are above 5 years. There are then additional 5 for children who are below 5 years. So those who are below 5 years could get all the 10 items, and those who are above 5 years get only 5. But when I looked at those items, I felt, these items are being used elsewhere to assess children of all ages. So I wanted to change that a little bit, as I just want to apply all these items to the children and see what happens. And so when I used all the 10 autism items in there, we had a reliability amongst those with autism of 0.60. But what was interesting about that is that, the items that are meant to catch, the additional items for the younger children, when I use those alone, they could actually, shoot up to an equivalent of an SRS in identifying these children. So to me, that is hope. That means some of these things could be tweaked to actually suit our areas. And in my argument later, I think these items should be used as a quick screening tool in the busy hospitals, that we do have, where these people don't have the time. But how do we get these children to specialists that actually know this work? Amongst the non-SD, the controls, you would see that, the instruments had a better, reliability. This one, remember, it was at 0.60 here. It's at, it's catching about 7. It is screening out about 7 out of every 10 of people who actually don't have, an autism. So meaning it's giving us about 3 children who are, as false positives, that, these children could, have autism and yet it is not. So this is not bad in my view, because then either way, they will assess them at the next level and, they will be ruled out. But we want to be as efficient in terms of, ruling out those who don't have and, really bringing in those who are at risk. The SRS was better. Again, when you look at the 23Q, the 10 items amongst those without autism actually screened out about, 0.83 of these children. And when I applied, the 5 items meant to screen the younger children, it actually screened out all children who didn't have, autism, you would argue, because it's a 0.99. So it kind of, this child doesn't have autism, not all your totals will not tally, therein. And so that was that about the reliability of the instrument. You look at validity, really, is this thing measuring, is it differentiating between these children? So we are looking at the means, of the scores of these children and really if they're significantly different. And this is what you could see, in the ASD and NSD by the social communication questionnaire. You see that the children without autism had a mean of about 5.4 with this standard deviation of 3.7. Those with autism had a higher mean, which is about 4 times higher, and this was significant. And if you can see the effect size here of 4.0, that is very, very large, and this is significant. And of course, some people have argued, well, that is a very, very, large. Like, did you, that is not something easily seen in research. And the argument has been that, remember, I only had 2 groups of children, those children that have autism and those who don't. And like I told you in Uganda, most of the children I did see, or that you do see out there, are low functioning. So most of the language is impacted and there are lots of other things going on. And so really it would be some of the really low functioning cases versus those who are not. And so in my proposal later on, I'm thinking we could add, I'm to add a 3rd group of children that are just coming into a clinic. You administer this before they see a specialist, and then compare at the end what the outcome was based on that. And then I think this would come down. But either way, this is still too large. And even with that, I don't see it, coming so much below that. And the same for the social responsiveness scale. Now, for this 23Q, again, the Ugandan one, you see a moderate effect size. Despite them having a mean of 2.9 and this one a 4.0, it is moderate, it is significant. And so what it is telling us is that, yes, I think these instruments are, are doing well amongst, children with this. And so I say, fine, let's just classify them. And so classification, this is, I just wanted to show these graphs. Sensitivity, we want a balance between sensitivity and specificity. Sensitivity really is that if a child has autism, this instrument is going to pick them out. Specificity would be if a child doesn't have autism, it is going to push them out. You won't screen them in based on your totals. And so the balance there is really what is good. You need it to be doing 100% on both ways, that if you don't have, I never want to screen you in. If you really have, I want to screen you in. But unfortunately, those are the biomarker type that, you do the blood test and, you really know this child has malaria, this child has HIV, and, all of that, which we don't have for autism. So it's, it's a balance of the two. But like you did see, what I was showing you earlier on the other side is what we do see. We want a high sensitivity and we want a high specificity as well. So when you follow this graph, the receiver operator characteristic curve here, you do see that this SCQ is performing so well. And again, this is rare in research. But again, my argument is that these were extreme cases of, low functioning children versus children that are neurotypical, at least from what we did know. So what you see to the right of the screen are really the possible scores based on the SCQ. And again, I did cut out, what I could get the chain could go on, but basically this is what you inspect to see that, okay, they say 15 is a cut score for children that have autism. How is my 15 performing? Here, it may not be. So I'm going to rely on, 14 and 16. It is telling me that it could screen in about 9.6 of these children at 14. And then it could, screen out about 95% or, of these children, right? Because this is a one, we'll say one minus, whatever we do have here. So we say, 14 is doing well, but then it's giving me 95. What about those other, children that it may screen out and yet they actually have autism? So that is, we need to screen all of them in. And so I was making an argument that, for the Ugandan, I think we need to lower, for the Ugandan children, we need to lower from 15 to 10, because 10 is going to get us all these children. Sensitivity is going to be high. We'll screen all the children that have autism in, and have about 93% of children that don't have autism, screened out. Yeah, and so I felt like, yes, this has happened elsewhere. The scores of 15 are working for children in the US, but we will need to adjust the cut scores for the children in Uganda in order to be in position to, get as many of them as possible. The same applies to the social responsiveness scale. This one, like I told you earlier on, they say 70 if you're just in a community trying to screen any child who may be at risk. And so when you look at it based on, the output that we do have to the left of the screen, you do see that it's also performing excellent in actually, separating these two categories, those with autism, those without. But the issue is, are the cut scores that are provided for in the manual for the US children going to work for the children in Uganda? And, when I look at something that is close to 70, it is telling me, yes, 70 is doing so well. We are screening in about 98% of the children with, autism. And then we are screening out about 99%. So 70 is doing so well. But again, we'll have to, get into the data at that point and then use 70 as a cut score and see how it categorizes them. 85, which is for the clinical, it would be somewhere here, right? I see we lose close to 17% of, the children that would potentially screen in, at the bottom here. And, even if it could actually, screen out all of, the children without autism, we still miss a lot of this. So it's a balance of, what cut score could apply. And for this, I was arguing that 62, if we lowered, it to 62, we probably will have, screen out as many children as possible and screen in as many children, as we can. Because here with 62, we could get all children who have autism based on the sample they do have screened in, and we could screen out about 97% of the children that don't have. And so the little percentage that remains is not so much of a lost time in terms of the professionals trying to really, assess this child, given the long benches that we know they usually have with, people trying to get this diagnosis. Now, when I looked at the 23Q again, which I was super interested in, you'd see how it wasn't as good as these ones. And this is normally what you'd see in most of the instruments. But again, this is using 1 as a cut score, because for it was basically drop it in the community. If a parent responds yes to any of the 10 items, to any of the items therein, you should send that child for further, examination. When you use the 1, you can really see that it's screening in everyone. Yes, we get all the children with autism, but also when you look at this, it kind of screens out none, right? So balancing it, so here we look at 1 here probably would be good. We get 96% 1 minus this, we screen out close to all the children without. But again, when I applied to the data, that wasn't working. And so all in all, I argued that to get a proper balance, we needed 3 about here. So we'd get about 76% of these children and, screen out about, 1 minus this would probably, screen about 70%, of those children. But again, this is based on using the 10 items. But if we use the 5, it was performing, the 5 items was, it was performing just as good as, this. And that is the argument I'm kind of making. So this is just a summary of all those graphs that I was talking about and how they really performed. So 1 wasn't doing really, well for the social communication questionnaire. I mean, for the 23Q. 85, like I did tell you, did so well in terms of screening out all the children, but we missed close to 18% of the children that would potentially be screened in as, true positives. 70 did so well, like we did see, almost screened out all children that didn't have autism and brought in all those that had. And the same was here. 15 actually performed so well for the social communication questionnaire, although I argued that, missing the 2% would be, if we could lower it further to the 10, it would be better. So, and that is what I was talking about. So we explored, like you did see, it's a give and take. We lower it to 10, we get all those who have autism, but we miss about 7% of those that don't. So what do we do with that? And so it's a balance. We can send those for further analysis, maybe 1, 2 children, as compared to, 10 children that, the specialists have to spend their time screening and then, screening out. We could better streamline that. The same, so this is what I was telling with the 62, it performed better than both these. So I am proposing this would be lowered for the Ugandan population to, a CAT score of 62. This was the social the 23 question screen that I was telling you about, that I argue we should bring the CAT score to 3. If a parent responds to 3 items as a yes, they should go see a specialist, and that child should be assessed for autism. Not the best, but there is a balance, other than the one which is, screening in all of this and actually bringing in all the children, that don't have autism. So it's a lot of, wasted time, and yet these people could deal with lots of, other people as well, out there. So I guess I was talking about the implications as we're going on, but yes, it's important to validate these instruments. The CAT scores that are working for the US don't work in the Ugandan setup. They do well, but we could make it better. I think we should also do correlations. So the ADI and ADOS are the, the gold standard, kind of instruments here that, psychologists will use to actually have a concrete, diagnosis. For most of the insurances and all of this, they would demand that you do take at least the autism diagnostic observation schedule or the IDIR. And so these would be the next level. We need to look at how they work and then compare them to those, the correlations. How are they working, so we can make them even better? We actually need shorter but psychometrically sound instruments which are tired. If we have 5 questions that are screening in, children that are at high risk, and then we have probably another 10 or 15 as, additional questions we could give the parent, and we keep eliminating, the better. Having 65 items and a parent responding to all of this, and there are probably 2 instruments would be tough. So shorter, instruments would actually work better. Further ASD research with developmental disabilities. Matthew was talking about all of the things that are going on with HIV and, all of this. These are some of the issues that are, we are looking at now. We are saying, is there a relationship between antiretroviral therapy and developmental disorders? And we have very interesting preliminary, outcomes based on, what type of ARV did the mother receive, and what is it saying about different? It could be ADHD, autism spectrum disorder, and all of this. And we have reason to believe that we may have quite good data that is going to cause some arguments in the field. And so I think that is an area to really explore. Like we did say, we Africans should also be on the table advancing some of the things, because if we do see as trained researchers, and we do see something that may actually help down the road, then we need to drum it up, and we need to get those solutions on the ground. So it will be interesting. This is that I will be presenting at the if all goes well, International AIDS Society meet this year, and we'll be working with that. So I argue clinically that the SRS social communication questionnaire and the 23Q are actually useful. Doesn't matter whether we give the SRS or SCQ to a parent, should be in position to point us to, a good area that, yes, this child has a very high likelihood of having autism, or this child, it's something else that could be going on. We need to figure it out. It's probably not autism because this is not working out. We have to lower the CAT scores, like I did say. We have to include the third group of children who just suspect to have autism but don't have a confirmation, but are actually at the clinic. Yep, let's see. Yeah, of course, this is the first study to examine psychometric properties of these two instruments and the 10 autism-specific questions in a Ugandan context. I could argue, that it's just the start, but I think this has far implications for Africa, as a whole. We have different cultures, and all of that, but I do think starting the argument of we need to apply this to our context and really see what works for us would be a good thing. This was done by trained clinical psychologists. The research assistants I did have were trained. They were dealing with this on a daily at this. Yes, the sample size is still small, but I do believe as I move it up for publication, I have about 200 children right now. Not so bad, but I think would still tell a very good story out there as we continue screening in. So again, these two instruments were normed in the US, but they're appropriate for use in Uganda. We will need to reduce, the scores, adjust them. And we need to try the 5 autism-specific items for the younger children, just as quick assessment, kind of screening tools for children suspected of autism, and see how those perform. Those could really reduce, on the amount of time, specialists spend trying to diagnose these children. So thank you. Hopefully, I was in position to still be within my time. Yes, but yeah, I welcome any questions, comments.
My connection is not the best, and I would like, if you guys can hear me, to be guided by Damaris. As I
All right, it looks like Tutilo has challenges with the internet. I think we can, I don't think I see any question on the chat, but you please feel free to, we have about 4 minutes, and please feel free, if you have a question, you can unmute yourself and ask, or you can type it down in the chat, but I can really encourage you to ask it verbally because you don't have that much time. If you would just be open and ask your question. Oh, and Lutumi, yes, please go ahead. You are muted though.
First of all, thank you so much for such an edifying presentation. I am interested to learn what research has been done for adults, especially on the African continent, who were never diagnosed, because looks like this is a very fledgling area on the African continent. So what has your area of study done for individuals, say, who are 30 and above, who are autistic?
Okay, thank you. Do I take one as to go? So yes, and to be straight to the point, there is not much, as we are just starting to really get our feet to the ground. Not much has been done for the adults with autism. But some of these instruments are actually, sensitive to get people as far off as 70 years. We just need to have them come through the clinic, and then we could, have those. Again, autism, yes, it has been around for a while, but the awareness has been so rapid, but not for so many, years. And so I believe that for those who are above 30 or more, if we hadn't caught them for now, it will take quite an effort. And those are some of the questions I keep asking myself: where are these? Because these people are growing, where are they disappearing to? We don't see them a lot. We don't see special needs schools catering for example, post-primary. There are very few, vocational type or special, special programming, education type, training type, institutions that are out there. So it's a population that needs to be, really looked into. And it was one of the things the mothers talked about in the conversation I had with them in the paper, that I submitted to them. Yeah.
Thank you very much.
May I ask my question?
Sure.
My questions are very brief. There are two. One of them, and I'm asking them from a position of a layman. I really know nothing about this area, and I've learned so much from you. Thank you so much. First question is, the video you showed us at the beginning.
Yeah.
Is everything there scientifically accurate? I'd like you to comment on that. This is a journalist who is giving us a research story. Is everything there he says or his respondents say scientifically accurate? I'm raising this question upon hearing a mother saying the daughter received an expired vaccine and she thinks that this is the cause of her daughter's condition. So I'd like you to comment on the veracity of what we saw in the video.
Yeah, so there are lots of, at least what we do now, based on research, like I did say, is that this is majorly genetic, in terms of origin. 80%, of the autism, at least that we do. There are some that there are some people who seem to say, there are some researchers out there who seem to say, yes, it is possible that there could be, environmental things or other things outside genetics that could contribute. And this is an area I think we have to explore more. But at least for now, concretely, based on research, we know it's genetic. So the issue around the vaccine and all of that is a true reflection of what is out there in the society, but not backed up by research. And that's why I played it, saying, oh, it is true, for example, that I've met parents who say their children are sensitive to, food, certain specific food textures. And, so they're told, don't eat sugary things, have gluten-free, products and, all of those. And even this, there's little research that is backing that up. All of us know that at least if somebody takes sugary stuff, you get hyperactive, right? And you can imagine if this child, like I did say, there could be an element of ADHD that's going on as well, therein. If the child gets much more hyperactive, what do you do? So it will stop this food. And so the issue of are these children even, getting the best nutrition there is a question that should be asked. But for sure, there are lots of falsehoods out there that are not backed up with research that people need to focus on and actually get some information for us.
The last question, I come from the area of literary studies. I would like to know from your research what autism is called in the Ugandan languages you work with. Because I think if we pick that up from the different languages, it can give us an idea of the local vocabularies and the local understandings of this condition. Thank you.
Yeah, so honestly speaking, that is, you got me there, because most of the parents, even when they're talking in the local, language, Uganda, whatever, say, omwana ina autism, the child has autism. There seems not to be a proper word. Other community members could say omwana kasiru, the child is dumb, the child is, they use all those other, things, Kasiru, like the child doesn't talk, all of those, but the proper name, I think they still stick with autism, based on the parents I've talked with, and even in the community. I haven't gotten a proper, name that is out there now. Yep, that's a good one to think about.
Okay. There's one question here that we're really out of time. I hope you can bear with me for a few more minutes. There's a question here that asks, thanks, Dr. Okay. For study 1, is the social stigma varying by urban and rural areas?
The mothers I talked to were actually urban. It didn't matter. And for them, these were fairly well-to-do mothers. And so they were associating their, being fairly well off, that you can stay in a house, own your house and things, to sacrificing, a child. And most of these mothers were business women and, things like that. So the community was not sparing them as well. Say, no, that one has probably just sacrificed that child so they, they can go on. So it's not. In the village, I don't think it will be any different, because, talking to or reading into this and interfacing some of the mothers as well, they are not saved. It is where they're saying, maybe your ancestors did something wrong. It's a child out of incest. You need to appease the spirits, so things like that. So I think it is, we would say, honestly speaking, that maybe the mothers in the urban area could get some people who are actually sensitive to, autism and understand something. Yeah.
All right. Wow. I think we did just run out of time. I know there could be more questions from the audience, and I would really encourage you to share those questions either with me or with Dr. Awadu. I will, Jorem, if you can please share your, and Marty too, please, if you can share your email addresses down here. But I can still as well be able to share those with whoever that is interested, because I know there are questions for sure. It's only that we didn't have enough time. So at this point, I want to first thank the speakers, Dr. Awadu and Dr. Kelepile. I know I'm wrong again, but thank you so much for sparing time, especially being very late in Botswana right now. It's a sacrifice, and we really definitely appreciate your time and the work, the research work that you shared with us on what's going on with HIV and COVID-19 right now in Botswana. Very great work, and thank you so much. Dr. Awadu as well, we definitely appreciate. You said this is the second time you're presenting this, but it felt and sounded very different. New information, and we appreciate. You can do this 3 times, because usually we have different audiences every single time. So with everyone that was able to join us today, we also want to thank you so much. I see some stuff in the chat. I'm not going to go into those, but please feel free to continue the discussion over the email in whichever way that you can. I'm happy to be able to connect you with both presenters if you didn't have a chance to ask your question. Next, in 2 weeks, not next week, but on March 4th, we're going to have another discussion, and I please welcome you all to attend. If your time allows. It's going to focus on Angola and the Gambia. The schedule, I know, says South Africa, but it's going to be the Gambia in the place of South Africa. And we're going to talk about China and Africa. Is the relationship working? I don't know. Please come back on 4th March and let's discuss this. Otherwise, thank you so much, and look forward to seeing you back again.